Welcome to the deep dive. You're here because you want to quickly understand important topics, and today we're tackling something vital in pediatric health that might not be top of mind: acute arterial occlusion in children. No matter your background, we'll extract what you need to know.
Exactly. For this deep dive, we've got chapters from Rutherford's Vascular Surgery and Endovascular Therapy 10th edition, and we're really zeroing in on why this condition in children is, well, uniquely challenging. It's quite distinct from what doctors see in adult patients.
Okay, let's unpack this then. Our goal, really, is to give you a clear picture of acute arterial occlusion in kids. The causes, how it's diagnosed, treatment approaches, and importantly, the long-term implications. We want to provide real understanding without sort of overwhelming you with excessive detail.
Right.
So what makes a blocked artery in a child so different from one in an adult? Where do we start?
That really is the essential first question. As the textbook highlights, children aren't just small adults, especially when it comes to their blood vessels. Their artery walls are still developing. That makes them more fragile, more susceptible to injury, whether it's from, say, a medical procedure or some kind of accidental trauma.
Fragile, right?
And this inherent fragility makes repairing these tiny vessels much, much more complex. Think about it this way. In adults, arterial blockages often come from years of plaque buildup, right? A slow, chronic thing.
Yeah, atherosclerosis.
Exactly. But in children, these are usually acute events, the sudden injury or maybe a consequence of a necessary medical intervention. This fundamental difference, it basically dictates everything from the underlying mechanisms to how we approach treatment.
And it's not just the physical structure, is it? There's more going on, I assume.
Absolutely. Children, particularly the very young ones, they tend to have a much more pronounced vasoconstriction response.
Vasoconstriction,
Right.
meaning the vessel tightens up.
Precisely. When their arteries are manipulated, they clamp down hard. Imagine trying to work on a very delicate, tiny hose that just keeps squeezing shut.
Okay, yeah, I can picture that being a nightmare.
It makes any surgical or catheter-based procedure even more difficult. Plus, their bodies process medications differently. Drugs like blood thinners, clot-dissolving agents, they're metabolized differently in children, especially newborns. So the dosages, the monitoring, it all needs to be incredibly precise.
So it sounds like a highly specialized area of medicine then.
It really is. And because acute arterial occlusion is thankfully quite rare in children, we don't have a ton of large prospective studies to definitively guide treatment.
Ah, okay. So how are decisions made?
Well, recommendations often rely heavily on the accumulated experience of experts in the field. It really underscores the importance of a collaborative team approach. You need specialists from pediatrics, cardiology, vascular surgery, interventional radiology, all working together.
Makes sense. Okay, so we understand it's different. It requires specialized expertise. How often does this actually happen in children? And what are the primary causes we're seeing?
Acute arterial occlusion in children is indeed rare. A large analysis of U.S. hospital discharge data back in 2012 estimated the incidence at about 2.35 cases per 10,000 discharges.
Okay, so not common.
Not common. But what's really fascinating here is how much the causes vary depending on the child's age. It's quite distinct.
Right. Tell us more about how age plays into it. What causes it in the really young ones?
For younger children, especially those under 6 months old, the leading cause is iatrogenic.
Iatrogenic, meaning related to medical procedures.
Exactly. Occlusion of the iliofemoral artery, that's the big artery in the groin and upper thigh area, is particularly common in this age group, and the main procedure implicated: femoral artery catheterization.
That's when they insert a small tube, a catheter, into the femoral artery, right? Why does that carry such a risk in these little babies?
Precisely. And it's often a necessary procedure for critical care. Things like continuous blood pressure monitoring in very sick babies during complex cardiac interventions, ECMO, that's extracorporeal membrane oxygenation, basically life support and other vital treatments. The textbook points to around a 2% risk of injury requiring repair just from this procedure alone. That makes it the #1 cause of acute limb ischemia, lack of blood flow to the limb in this young population.
2%.
Yeah.
That sounds quite high for a necessary procedure.
It is significant. And the risk of thrombosis, actual blood clot formation, during cardiac catheterization in infants might be even higher than the 1.3% suggested by that database analysis. Some prospective studies where they specifically looked for it indicate rates may be as high as 8% or even 9%. Wow. Imagine trying to navigate even a thin wire through a vessel that's maybe only about as wide as the tip of a ballpoint pen. The slightest irritation can trigger a clot in such a small space.
Okay, so what's actually happening on a physical level to cause these clots?
Well, several factors come into play. The act of cannulating the artery, just putting the catheter in, can cause direct injury to the delicate inner lining, the endothelium. And that injury can trigger the body's clotting cascade. Then there's the size mismatch issue. The catheters and sheaths used, even the smallest ones, can be relatively large compared to these tiny infant arteries.
Right.
And that problem gets worse with the intense vasoconstriction we talked about. The vessel clamping down makes the space even tighter.
Okay.
Plus, other factors like inadequate blood thinning medication, the naturally higher red blood cell count hematocrit in newborns, and even things like dehydration or sepsis can also contribute to the risk.
You mentioned how incredibly small these vessels are. Can you give us a better sense of scale? Just how tiny are we talking?
Absolutely. There are some helpful nomograms, basically charts, developed by Tad Fail and colleagues. They show the average diameter of the femoral artery at birth is only about 2 millimeters.
2 millimeters, that's tiny.
Incredibly small. By 1 year old, it's maybe increased to around 2.5 millimeters, and by the time a child is 4, it's roughly 4 millimeters.
So you can see how even a small catheter.
Exactly. Even a seemingly small catheter can cause a significant blockage or injury in a vessel that narrow. And studies that use routine ultrasound after cardiac catheterization have found surprisingly high rates of femoral thrombosis in infants under 6 months. One study reported up to 23.4%.
23%.
Yeah, when they looked specifically with ultrasound. And this was clearly correlated with lower weight babies, larger sheath size relative to the vessel diameter, and longer procedure times. Basically, the smaller the baby and the longer or more complex the procedure, the greater the risk.
Okay, that paints a clear picture. So longer, more complex procedures on the smallest babies carry the highest risk. Are there other procedure-related causes in this youngest group?
Yes, umbilical artery catheters. They're frequently used in newborns in the NICU for monitoring and giving meds. They also carry a risk of causing symptomatic arterial thrombosis, maybe around 1% to 3%.
But what influences that risk?
Well, things like whether the baby gets adequate doses of heparin, which is a blood thinner, and also the precise positioning of the catheter tip within the aorta. Where that tip sits matters.
Okay, that covers the risks for the youngest patients. What happens as children get older? What are the main causes of acute arterial occlusion in older children and, say, teenagers?
Right, so as kids get older, the picture shifts. Trauma becomes the predominant cause.
Trauma, like accidents.
Exactly. This can include blunt force injuries, think car accidents, falls, maybe sports injuries, and also penetrating wounds, although less common than blunt trauma in kids.
Okay.
Interestingly, these traumatic injuries are actually more common in the upper extremities, so the arms and hands. One study found about 61% of cases were in the upper limb compared to maybe 30% in the legs.
That's different from adults, isn't it?
It is. And also, unlike adults with vascular trauma, penetrating injuries like stab wounds or gunshot wounds are less frequent in this pediatric age group overall. One study looked at nearly 1,400 pediatric trauma patients and found 23 of them had vascular injuries serious enough to need surgery.
But overall, it's less common than in adult trauma.
Yeah, the overall incidence of significant vascular injury is lower in children compared to adults, maybe around 0.6% versus nearly 3 times higher in adults.
Okay, so for older kids, accidents are the primary driver. What about cases where it's not from a medical procedure or an obvious injury? Does that happen?
It does, but those are classified as spontaneous occlusions, and they're quite rare in children.
Spontaneous, meaning out of the blue.
Pretty much. When they do occur, they're usually linked to some underlying condition that makes the blood clot too easily. We call this a hypercoagulable state.
Okay, like what kind of conditions?
It could be inherited factors, things like deficiencies in natural anticoagulants, proteins like antithrombin, protein C or protein S, or genetic mutations like factor V Leiden.
Right, inherited clotting disorders.
Exactly. Or it could be acquired conditions, things like DIC, that's disseminated intravascular coagulation, a really serious condition where the body's clotting system just goes haywire, or nephrotic syndrome, antiphospholipid syndrome. Also, acute inflammation from severe infections like sepsis or chronic inflammatory diseases, autoimmune disorders, even a rare reaction to heparin called HIT, heparin-induced thrombocytopenia.
Wow, quite a list.
Yeah, and these spontaneous occlusions often tend to affect arteries further down the limbs, maybe more distal arteries, rather than the main central ones.
This gives us a really good framework for understanding who is at risk and the different reasons why these blockages might happen. So How does a doctor recognize that a child might be experiencing an acute arterial occlusion? What are the signs, the clues?
Well, for those iatrogenic causes, the ones related to procedures, the most important thing is just having a high index of suspicion.
Being vigilant.
Exactly. If a child has an arterial line in, or recently had a cardiac cath, or was on ECMO or bypass, any signs of reduced blood flow in that limb need to be taken very seriously, even after seemingly minor things like an arterial blood gas sample poke. And you also have to consider accidental arterial puncture when someone was trying to get venous access.
Okay, so suspicion is key. What are the actual physical signs doctors look for?
In older children, the signs are pretty similar to what we see in adults. The affected arm or leg might feel cool to the touch.
Oh, miss. Okay.
It might look pale or maybe mottled, kind of patchy discoloration. And the pulses in that limb, feeling for the pulse at the wrist or ankle, might be weaker or completely absent compared to the other side.
Right.
The child might also complain of pain. And then a late sign, which indicates pretty severe ischemia, is loss of movement or sensation in the limb.
And what about in the little ones, the babies and infants? You said it can be subtle.
Very subtle. That's where a handheld Doppler ultrasound device becomes incredibly valuable.
The Doppler, right?
Yeah.
How does that help?
Well, you can use the Doppler to listen to the blood flow signal in both limbs, the affected one and the unaffected one, and compare them. You listen to the characteristics of the sound. An experienced clinician can often detect a problem, like a dampened or absent signal, even before those classic signs like coolness or pallor are obvious.
Interesting.
And critically, decreased spontaneous movement of a limb in an infant. If a baby just isn't kicking one leg as much or moving an arm, that can be a really important early indicator of significant ischemia. One review found that about 78% of catheter-associated cases actually showed signs of ischemia right at the initial examination.
So even just a subtle decrease in how much a baby is moving their arm or leg could be a major red flag.
Absolutely.
Yeah.
And if the collateral circulation, that network of smaller backup blood vessels, isn't great or can't compensate, the limb can quickly become profoundly ischemic, really cold, white, maybe even blue.
That sounds critical.
It is. And it's also important to remember that if a child has underlying heart or lung problems, those conditions can sometimes make it harder to spot the signs, or they might complicate the presentation. For instance, one study looking at infants with iliofemoral artery occlusion found that a huge majority, 89%, had a complete blockage, and almost half had no detectable blood flow below the ankle using Doppler.
Wow. What about lab tests? Can blood work help pin this down?
Lab findings are often nonspecific for the occlusion itself, meaning the blood test won't definitively say, yes, there's a blockage.
Okay.
But they provide really important information for managing the child overall. For example, labs might show hemoconcentration, or a high white blood cell count suggesting infection, maybe an increased platelet count. If a child is already on blood thinners, monitoring their coagulation levels, like the anti-ags that we discussed, is crucial.
Right.
A low or suddenly dropping platelet count could raise suspicion for things like DIC or that heparin reaction, HIT, and if there's been significant muscle damage because of the lack of blood flow.
Ischemia to the muscle.
Right. Then we might see elevated levels of an enzyme called creatine phosphokinase, CPK, and maybe myoglobin in the urine. And depending on what the doctor suspects is the underlying cause, maybe a clotting disorder or inflammation-specific coagulation tests or tests for autoimmune issues might be ordered.
Okay. Labs are supportive. And then there's imaging. What's the role of different types of scans here?
Imaging is critical. Duplex ultrasound is very often the first-line imaging choice.
Why ultrasound first?
Well, it's readily available. You can do it quickly right at the bedside. It's relatively inexpensive. There's no radiation involved, which is a big plus in kids.
Definitely.
And you can repeat it easily to monitor things. In the hands of an experienced pediatric vascular sonographer, ultrasound can often provide a definitive diagnosis. It lets you directly see the clot and assess the blood flow, or lack thereof.
Okay. What about more advanced imaging, like CT or MRI scans?
CT angiography, or CTA, and contrast-enhanced MR angiography, CRA, can be very helpful. They give a more detailed map, showing the precise location and how extensive the blockage or injury is. CTA is often preferred in trauma cases because it's fast and can also look for other injuries at the same time.
But there are downsides.
There are. Both often require general anesthesia in young children, so they stay perfectly still for the scan.
Right. Anesthesia has its own risks.
It does. And CTA involves exposure to ionizing radiation, which we always try to minimize in kids. Plus, the contrast dye used in both carries a small risk of kidney problems, especially in sick children. CMR avoids radiation, but it takes longer and can be logistically harder to arrange quickly in an acute situation.
So what's considered the absolute best test, the gold standard for looking at the arteries in detail?
That would be digital subtraction angiography, or DSA.
DISA.
Yeah. It gives a very detailed, high-resolution picture of the artery's inner lining. It shows exactly how narrowed it is, the full extent of the blockage, and any collateral vessels that might have developed.
And can you do anything else during a DSA?
Yes, that's a key advantage. DSA allows for the immediate possibility of performing endovascular interventions right then and there. Things like using catheters to remove the clot or performing balloon angioplasty.
But it's invasive.
It is invasive, yes. It carries its own risks, like potential injury to blood vessels, especially in tiny kids, and it also involves radiation exposure. Although the amount of contrast dye needed might actually be less than for a CTA sometimes.
Okay, so we have a good handle on how these occlusions happen and how they're diagnosed. Now, let's move to treatment. How are these young patients managed once a blockage is identified? What are the options?
Right. Well, treatment in older children, say teenagers, generally follows the same principles used in adult vascular surgery. But, as we've been discussing, neonates, infants, and toddlers, they present really unique challenges.
Because of the small vessels and the spasm.
Exactly. They're small, delicate, spasm-prone blood vessels, and just the size difference between their little arteries and the standard adult surgical tools. It makes things tricky. In the very youngest patients, specialized microvascular surgical techniques might be needed, often involving surgeons with specific expertise in operating on tiny structures.
We touched on this earlier, but it sounds like the way a child's body responds might also steer the treatment approach.
That's absolutely right. Children often seem to tolerate moderate levels of ischemia, reduced blood flow, better than adults do. They also seem to have a greater natural ability for their bodies to break down and dissolve clots in arteries that are otherwise healthy.
Recanalization, is that the term?
Yes, recanalization.
Yeah.
And they can often develop more robust collateral circulation over time, those backup pathways.
Right.
Because of this, and also because historically, the outcomes of open surgical repair in very young infants weren't always great.
Right.
The main approach for many of those iatrogenic iliofemoral occlusions, the ones caused by catheters, has shifted more towards non-operative management initially.
Okay. But trauma is different.
Yes, it's important to distinguish. Pediatric vascular trauma is still largely managed surgically, often needing direct repair.
So let's focus on the iatrogenic cases first. What does non-operative management usually involve?
Anticoagulation. Using blood-thinning medications is really the cornerstone, the contemporary first-line treatment for iatrogenic femoral thrombosis in children.
So heparin.
Typically, yes. Unfractionated heparin, given as continuous intravenous drip, is often preferred initially. Its main advantage is that its effects can be stopped and reversed quickly if bleeding occurs or if the child suddenly needs surgery.
Okay.
Low molecular weight heparin, which is given as shots under the skin, is also used successfully in many centers. But either way, it's absolutely critical to involve a pediatric hematologist or a specialized pharmacist.
Why is that so critical?
Because, as we said, children metabolize these drugs differently than adults, especially infants and neonates. Getting the dose right and monitoring it closely is paramount. The ACC-PC CHEST guidelines recommend starting heparin promptly and also removing any indwelling catheter that might be contributing to the clot.
How do doctors know if the heparin dose is right in a child? What are they monitoring?
That's a great question. The standard blood test used in adults to monitor heparin, the APTT, may not be as reliable in children.
No, okay.
So many experts now prefer monitoring the anti-SAT activity level instead. There are specific target ranges for anti-SAT depending on whether it's unfractionated heparin or low molecular weight heparin.
Okay, anti-Zaxa levels. And besides blood tests?
Careful, regular physical exams of the affected limb are essential, looking for changes in color, temperature, pulses. And repeat imaging, usually with Doppler ultrasound, is crucial to monitor what's happening with the clot. Is it shrinking? Is blood flow improving? Or is it getting worse, despite the anticoagulation?
And if it gets worse?
If the clot progresses, or if the limb starts showing signs of severe ischemia, then you have to escalate treatment. That might mean moving to thrombolysis or even surgical intervention.
How long would a child typically stay on blood thinners for this kind of iatrogenic clot?
The recommendations for duration can vary a bit. Some guidelines suggest maybe 5 to 7 days. Others recommend longer courses, perhaps 6 weeks, followed by an ultrasound to check on the clot. Some centers will continue anticoagulation, often switching to low molecular weight heparin for home use, and do repeat ultrasounds every few weeks until the thrombus has completely resolved.
And does anticoagulation alone work often?
It seems to. Studies have shown that anticoagulation alone can lead to restoration of blood flow in roughly 70% of children within about 30 days. The most common complication reported is minor bleeding.
Okay, 70% is pretty good. What about the other 30%, or cases where things are more severe, when blood thinners just aren't enough? What's the next step?
Right. In situations where anticoagulation fails to improve blood flow adequately, or if the limb ischemia is severe from the start, then thrombolysis might be considered.
Thrombolysis using those powerful clot-busting drugs.
Exactly. Using medications to actively break down the blood clot. The main drug used is tissue plasminogen activator, or TPA.
Are there kids who can't get TPA?
Yes, the contraindications are generally similar to adults' recent surgery, bleeding disorders, head trauma, etc. But importantly, extreme prematurity is also usually a contraindication, mainly due to the increased risk of bleeding in the brain in very premature infants.
Okay. And how is the dose decided?
That's a key point. There isn't really a standardized pediatric dose for TPA, so the dosing and how long the infusion runs are carefully determined by the clinical team, constantly weighing the potential benefit of dissolving the clot against the risk of bleeding complications. It's a fine balance.
How is the TPA actually given to children in these cases? Is it like the heparin drip?
Systemic administration is the most common way. That means the drug is given through an IV line and circulates throughout the body.
Okay.
However, there are some reports and growing interest in using catheter-directed thrombolysis in pediatric patients too. That's where a catheter is carefully guided right to the site of the clot, allowing for a more targeted, localized delivery of the TPA.
Does that have advantages?
Potentially, yes. The idea is you might be able to use a lower overall dose, achieve a higher concentration right at the clot, and maybe reduce the risk of systemic bleeding.
Makes sense. You mentioned the dosing varies.
It really does in the published studies. The 2012 ACCP CHEST guideline mentions a common protocol, but some more recent studies have actually shown good results using much lower doses of TPA given over shorter periods, and they reported potentially fewer bleeding complications with those lower dose regimens.
Bleeding seems like the major worry with TPA. How is that managed?
It absolutely is the major concern. That's why meticulous lab monitoring is essential before, during, and after thrombolysis.
What labs are they watching closely?
Things like complete blood counts, especially platelets, clotting factors like PT and APTT, and fibrinogen levels. Fibrinogen is one of the key proteins needed for clotting, and TPA breaks it down.
So if fibrinogen gets too low,
If it drops too low, they might need to give cryoprecipitate or fresh frozen plasma to replenish those clotting factors. And ideally, the child's platelet count should be above 100,000 before starting TPA.
okay.
Often, a low dose of heparin is actually given at the same time as the TPA. That might sound counterintuitive, but it helps prevent new clots from forming while the TPA works on the existing one.
And if bleeding does happen?
Any bleeding needs to be managed immediately. That might mean stopping the TPA infusion, giving blood products like platelets or plasma, or sometimes specific medications to reverse the TPA's effects. So while thrombolysis can be a very effective bailout when anticoagulation isn't enough, bleeding is a definite risk, and longer infusions or higher doses can increase that risk.
Okay. So when do they have to resort to more invasive options like open surgery or maybe endovascular procedures?
Right, open surgical or endovascular revascularization, basically. Procedures to restore blood flow directly are typically reserved for a few situations. One is limb-threatening or life-threatening ischemia that just isn't getting better, despite non-operative treatment in those iatrogenic cases.
Okay.
And the other main scenario is acute arterial occlusion that results from traumatic injury. As we said, trauma is often managed surgically up front.
And how feasible are these procedures in the tiniest infants?
That remains a huge challenge. In infants and neonates, the very small vessel size and their tendency to spasm can significantly limit what's technically possible, both for open surgery and endovascular approaches.
So what can be done?
Well, options might include direct surgical removal of the clot using very, very small Fogarty catheters. These are tiny balloon catheters. Or direct repair of the damaged artery, maybe patching it. Sometimes it requires microvascular surgical techniques, perhaps even involving collaboration with plastic or hand surgeons who are experts in working with tiny vessels, maybe using vein grafts or creating bypasses.
What about in older children and teenagers where the vessels are a bit bigger?
In older kids, whose vessels are larger and more like adults, standard adult surgical techniques can often be used successfully.
Like what?
Things like direct surgical exploration of the artery, thrombectomy, surgically sucking out the clot, basically repair of the damaged vessel wall, or maybe using a piece of the patient's own saphenous vein from their leg to create a bypass around the blocked segment. In some complex trauma cases, prosthetic grafts might be used, at least temporarily.
And endovascular options inside the vessel?
Yes, those are becoming increasingly utilized in older children too. Things like catheter-directed thrombolysis, which we discussed, also mechanical thrombectomy, using devices to physically break up or remove the clot, balloon angioplasty to widen the narrowed area, and sometimes stenting, placing a small metal mesh tube to hold the vessel open.
You keep mentioning vessel spasm as a challenge, especially in the little ones. How do surgeons and interventionalists try to deal with that during these procedures?
Yeah, it's constant concern. They use several strategies. Keeping the operating room warm helps. Being extremely gentle when handling the vessel is crucial. They also use topical medications applied directly onto the outside of the artery.
What kind of medications?
Things like warm saline solution, nitroglycerin, papaverine, milrinone, even lidocaine. These drugs help relax the smooth muscle in the artery wall and reduce spasm. For endovascular procedures, they can sometimes inject nitroglycerin directly inside the artery through the catheter to help open it up.
Despite these efforts, you mentioned earlier that the outcomes after open surgery in infants haven't always been great.
Unfortunately, yes. The long-term success rates, meaning keeping the vessel open, after open surgical revascularization in infants and neonates have historically been poorer compared to older children or adults. Those small vessels are just prone to reclotting.
What about the outcomes specifically for traumatic arterial injuries in kids? Is that different?
The outcomes there are more variable. They really depend heavily on how severe the injury is, where it's located, and if there are other associated injuries like broken bones or nerve damage. Studies have reported overall mortality rates around 10% in pediatric vascular trauma series, which reflects the severity of these injuries. Amputation rates also vary quite a bit depending on the circumstances. And the decision between surgery versus non-operative management and trauma can also be influenced by the child's age and the specific type of arterial injury.
This has really covered the immediate recognition and the treatment approaches thoroughly. Let's shift focus now to the longer term. What are the potential consequences down the road for children who experience acute arterial occlusion, even if it's treated successfully at the time?
That's a really important question. Thankfully, the majority of children do recover well. The primary long-term goals are pretty straightforward, ensuring normal growth and normal function of the affected limb.
And can that happen even if the artery itself doesn't fully reopen?
Sometimes, yes, especially if good collateral circulation develops over time. Those backup vessels can sometimes provide enough blood flow for normal function at rest. However, and this is crucial, we have to remember that adequate blood flow, adequate perfusion plays a vital role in how tissues develop, especially in growing children.
Okay.
So insufficient blood flow, even if it doesn't cause obvious symptoms like pain when resting, can sometimes subtly hinder musculoskeletal growth over the long term. This makes decisions about whether late revascularization procedures might be beneficial quite complex, often relying on clinical judgment about the child's growth and development.
Are there subtle long-term issues that might fly under the radar initially?
Yes, definitely. An arterial occlusion that happens after, say, a catheterization procedure can sometimes go completely unnoticed if routine vascular screening isn't performed after the procedure before the child goes home.
So it could be missed.
It could be. Studies have actually shown that a significant percentage of children who had femoral catheterizations in infancy or early childhood were later found to have problems at the access site, like narrowing or blockage, when they came back years later for another procedure. Subtle differences in blood flow between the two limbs might also go unrecognized without specific vascular assessment.
And what problems might show up later as the child grows?
Well, things like claudication, that's pain or cramping in the leg muscles during exercise.
Like adults get with PAD.
Exactly, same symptom. Also, gait abnormalities, maybe a limp, and even measurable differences in limb length or limb circumference, the girth of the limb, might not become apparent until a child goes through a major growth spurt.
That sounds quite concerning that these things could emerge years later. Are there specific studies that have tracked these outcomes?
There are some, yes, although it's still an area where we need more long-term data. One important study by Taylor and colleagues followed children years after femoral artery catheterization in infancy. They found that over 40% still had persistent femoral artery occlusions and reduced blood flow, measured by ABI, in the affected leg.
40% is a lot.
It is. And significantly, some of these children experience measurable limb length discrepancies, even though they didn't complain of claudication. Other studies have reported similar findings, lead stenosis, or narrowing, or complete occlusion, developing in maybe a third of children who had a known catheter-associated thrombosis earlier. There are also case reports and series describing children with prior arterial injuries who later developed chronic ischemia, manifesting as claudication, limb length issues, even scoliosis, potentially related to uneven growth.
So while most kids do well, these studies really highlight that there's a potential for these subtle but significant long-term effects on growth and function.
Precisely. It emphasizes that ongoing monitoring and awareness are really important.
What does that mean practically?
Well, it's crucial to educate parents about the potential for these longer-term issues when their child is discharged after treatment for an acute arterial occlusion. Documenting the child's baseline vascular status carefully at discharge is also key.
And follow up.
Yes, regular follow-up appointments, perhaps including checks in a vascular lab with Doppler ultrasound, are generally recommended, especially after revascularization procedures. If any abnormalities are detected, particularly during periods of rapid growth, prompt referral back to a vascular specialist for further evaluation and potentially intervention should be considered. The goal is to support normal compensatory limb growth before the growth plates in the bones fuse.
This has been a truly insightful deep dive. It really covers a complex and, frankly, critical area of pediatric vascular health. To try and bring it all together, it seems absolutely clear that acute arterial occlusion in children is, well, it's its own distinct medical challenge, right? With unique causes depending on the child's age.
Yeah, definitely.
And it requires a highly specialized approach to both diagnosis and treatment that's really quite different from what we see in adults.
That's a great summary. I think we've highlighted how those iatrogenic injuries, especially from femoral artery catheterization, are the big concern in the youngest kids.
Right.
While trauma becomes more the issue in older children and teens,
Mhm.
the role of non-operative management, especially anticoagulation for those iatrogenic cases, is certainly evolving and often the first step now. But the technical challenges of actually treating these tiny, easily spasming vessels, they remain significant when intervention is needed.
Mhm.
And while the immediate outcomes are often good, that potential for subtle but significant long-term consequences, things that can impact a child's growth and limb development, that really underscores the critical need for careful follow-up and long-term monitoring.
So building on that, here's a final thought for you, our listener, to consider. Given this potential for sometimes silent but still significant vascular compromise in children after necessary procedures like catheterization or following traumatic injuries, what are the broader implications? Do we need more robust, maybe standardized long-term monitoring protocols? And how do we ensure comprehensive and ongoing parental education about these potential late issues? It really boils down to how we best balance the immediate needs for intervention with a proactive approach to identify and manage potential later growth-related problems. How do we ensure optimal limb health and development for these young patients as they grow up?
A crucial question indeed.
Thanks for joining us for this deep dive.